our AYAs have kind of unique outcomes in things like quality of life post-treatment and even during treatment compared to like other cancer patients who are not AYAs.
That's Dr. Allison Manikowski from the University of North Carolina. Her team shares insights from a multidisciplinary AYA cancer program in the latest edition of Oncology Issues. You'll hear more from her up next. Welcome back to Cancer Buzz. I'm your host, Summer Johnson. Adolescents and young adults, or AYAs for short, are patients 15 to 39 who've been diagnosed with cancer. It's a broad age range, and some patients can be treated with either pediatric or adult models of oncology care, but that can lead to gaps in their care, leaving patients to face worse cancer outcomes. Today, we'll hear from 3 experts from the UNC Lineberger Adolescent and Young Adult Cancer Program about their work. First up is Dr. Andrew Smitherman, or Smitty, as he's known by his colleagues. He's the AYA Medical Director.
The Adolescent and Young Adult Cancer Program at UNC was started in 2015, and the sole focus is providing age-appropriate, developmentally appropriate cancer care for adolescents and young adults this is a population who's often fallen between the cracks between pediatrics and adult medicine. And because of that, their cancer outcomes are often inferior to those of other populations. And so early on, UNC recognized that this population deserves a unique approach to cancer care. And so our program is dedicated to providing that care through medical cancer care, through psychosocial support, through access to clinical trials, mental health support. So pretty much a comprehensive multidisciplinary approach to care.
Why do you think participation in clinical trials is usually pretty low for AYAs?
Historically, I think that those opportunities haven't been there for adolescents and young adults. So often studies in the past have focused on younger patient populations or older patient populations, or may not have really focused on the cancer types that are more prevalent among adolescents and young adults. And so over the last 15, 20 years, the National Cancer Institute has really worked hard to create a panel of AYA-focused clinical trials so that the right sorts of trials are available for adolescents and young adults to access. And it's not only having the trials available, but you have to have providers who are aware of the trials, who are willing to enroll on those trials and offer them to patients. And then they have to be appealing for patients to participate in. So there's a lot of factors that have to line up in order for enrollment to be successful. The National Cancer Institute, through the last couple of decades, has worked hard to create what are called intergroup trials. And so these are trials that are partnerships between traditionally adult-focused cooperative groups or clinical trial groups and the pediatric cooperative group, the Children's Oncology Group. And so by partnering, we're able to expand access to relevant clinical trials to adolescents and young adults, also pool our resources so that we're able to increase awareness and increase accessibility across a greater area for these trials to be available for adolescents and young adults. And based on those efforts, we've seen a lot of success in enhancing our enrollment.
How was the UNC AYA program's Transition and Survivorship Clinic developed?
So the UNC AYA Transition and Survivorship Clinic really grew out of a need for survivors who are experiencing difficulty with transitioning back to life after cancer treatment. We've heard from many survivors that they often struggle with just the logistics of how to get back to school or get back to the workforce. Many are still experiencing physical, emotional, mental adverse effects from treatment that in many ways will make it more challenging for them to get back on track after cancer care. And many, I think, struggle with the thought that, well, I've got to get back to my baseline as it was before cancer care, often not recognizing that cancer has forever put them on a different trajectory and changed who they are and maybe their priorities. And so providing some space to help support patients as they go through that transition, I think is important. And also, too, to provide a place where patients get systematic, risk-based, survivorship-focused care. Often, patients will continue to follow up with their primary oncology team. We'll get that surveillance for cancer recurrence, maybe ongoing treatment if there are continued symptoms that patients are experiencing, but may not get survivorship-focused care. So thinking about how do we transition to life after cancer care? What's the surveillance that's necessary to help look for potential long-term side effects? And in this population who will have decades of life after cancer and its treatment, this is essential care. And so we created the Transition and Survivorship Clinic to help not only AYAs transition back to life after cancer care, but to be a partner in providing guidance around how we screen for or provide surveillance for potential long-term side effects, and think about how we can optimize health after cancer treatment too. And so we talk about things like sleep, mental health, diet, exercise, knowing that all of those aspects of life have been impacted by cancer and its treatment. And in order to have the best quality of life and best outcomes, we need to pay attention to all of those aspects of an AOA survivor's life. The clinic was designed to be multidisciplinary, and we think that that's an essential part of providing survivorship and transition care. So what I mean by that is not only is there a medical provider, so a medical provider like me as an MD or a nurse practitioner, Melissa Matson, who works with us, but also having a mental health provider as well. So having one of the social workers with our team providing care together is essential in being able to address comprehensively the needs of AOA survivors.
Tell us about your program's Be Loud infusion space.
We know that a cancer diagnosis as an adolescent or young adult is extremely isolating. Often teens are treated on the ped side, and so they're in areas where there's younger children, and conversely on the adult side, young adults are often in with a sea of older adults who are receiving cancer care. And so these individuals are often feeling like they're the only ones who are going through this at their age, and they're not. So the Be Loud Sophie infusion space was created with the purpose of allowing community or co-localization of young adults as they go through cancer care receiving infusions. So the area was completely designed by our AOA Patient Advisory Council or Advisory Board. They stressed the importance of having the ability to maybe push back a panel and communicate with the person in the chair beside you, or being able on some days to close that panel and have some more alone time. It has a very natural sort of theme to it. And that was one of the major recommendations from our advisory board, was help us feel like we're not in a hospital, that it's in a more natural environment. And that is such a cool tie back to Sophie Steiner, who was the inspiration for the UNC AOA Cancer Program. She was very much an individual who liked to be outdoors. She took pictures of nature, and some of her pictures are in the infusion space. There's not a lot of technology, as some would think that would be what many AOAs would want to see, but our advisory board said absolutely not. No TV screens, no loud shows on. There is access to individualized technology, so iPads and things like that if folks want. But the key is to provide that opportunity for connection. It's not a heavy hand. You have to connect, but the opportunity is there. The door is opened. And then having this co-localization, it offers opportunity for specialization of care as well. So the nursing staff who is in that space, they choose to work with young adults and have additional knowledge on resources and support for young adults. And so we think that not only does it elevate care through providing that opportunity for connection with others of similar age, but it provides opportunity for education and connection to resources.
Dr. Jacob Stein is the AYA Oncology Liaison on the UNC team. He's here to tell us more.
So I am a medical oncologist. Clinically, I take care of patients with sarcoma, which are a rare group of cancers. And I'm also a health services researcher. So I study cancer care delivery and try to figure out how to improve cancer care delivery, particularly to populations who've not been well served in the past. And that certainly includes the AYA population. As it relates to the AYA team, I'm the AYA medical liaison. And so I essentially work closely with, I take care of a lot of AYAs through my work as a sarcoma medical oncologist. And I work closely with all the members of the AYA team to improve care delivery, fill gaps, whatever it is that we need to do to improve the way that we're taking care of folks. And I also help advocate for the needs of the AYA program on, divisional meetings with my colleagues in medical oncology.
Dr. Stein, describe the biological factors that underpin AYA cancers.
Yeah. So this is a really important element of the challenges that we see with AYAs. We know there are some biological differences for cancers that show up in this age range, but it's also a little bit challenging to summarize quickly because this is such a wide range of cancers. So AYA cancer can include Hodgkin's lymphoma, leukemia, including ALL, but also AML. It can include testicular cancer, GYN malignancies, breast cancer, etc. And I'll discuss a little bit the cancers that I see, which are sarcomas. And so we know, for example, that osteosarcoma, which is one of the most common bone cancers in children, has significantly worse outcomes in AYAs, particularly in young adults, folks over the age of 18, as compared with their pediatric counterparts. So osteosarcoma is much more prevalent in younger kids, but if it happens in a teenager or a 20-year-old, their outcomes are going to be worse than their counterparts who are treated on the pediatric side and who are children. The same is true for Ewing sarcoma. So higher rates of metastatic disease at presentation, lower rates of treatment responsiveness. So the objective response rates are lower in AYAs as compared with pediatric populations. Another big example is breast cancer. We know that young women with breast cancer are far more likely to have triple negative breast cancer as compared with the more common hormone receptor positive breast cancer. And triple negative breast cancer is, of course, a higher risk, more aggressive form of the disease. And that's, again, much more prevalent amongst AYAs. In ALL, that's another common AYA malignancy, acute lymphoblastic leukemia. We know that AYAs are more likely to have Philadelphia chromosome positive disease that is traditionally thought of as an adverse prognostic factor, and they tend to do worse. I will say that that is an area of active study because now we have, BCR-ABL tyrosine kinase inhibitors, and so we can treat that Philadelphia chromosome in a way that we were not able to in historical data. So there are differences that have been typically associated with worse prognosis, although some of this, again, is evolving as we understand these cancers better and develop new treatments.
What about financial toxicity? How does that impact AYAs compared to other patient groups?
Yeah, so AYAs face some of the highest burden of financial toxicity of any patient group with cancer in the United States. And that is for a few reasons. Number one, obviously, somebody who's younger has less accumulated wealth, and so they have less ability to withstand, a significant expense on their health, like cancer diagnosis and treatment. They are earning less. They've had less time to accrue disability or vacation time. We also know that AYAs are one of the most underinsured or uninsured populations in the United States. And so that means often they are, at least initially, facing these diagnoses without any insurance at all to help defray the costs. I actually just recently published an analysis on this, that in the state of North Carolina, we looked at all of the patients diagnosed with cancer over about a 20-year span from 2000 to essentially current data. And we saw that of all of those cancer diagnoses, over half of the AYAs had no insurance claims within the year after diagnosis. And so that would suggest that potentially over half of AYAs have no insurance in the year following their cancer diagnosis. So that just leads to an enormous cost and financial burden on these young people.
How do you think we can improve survivorship care for this population?
Yeah, survivorship care, I think, is something that's talked about, but is often, unfortunately, neglected. It's a hard thing to do well, right? In medical oncology, we're pretty good at treating people. We're good at giving them the medications that they need, chemotherapy, checking labs, giving nausea meds for nausea. It's a lot harder to take good care of somebody who's done with treatment, who doesn't need all the lab monitoring and infusions, et cetera. But many of these young people are facing a lot of challenges as they sort of reintegrate into society, if you will, after this cancer treatment experience. I've had some young people tell me, even after the intense treatment of multi-agent chemo for Ewing sarcoma, that the hardest part was stopping treatment because suddenly there was nobody there to help, nobody checking in on them, nobody talking to them and helping them get their challenges and needs met. So how do we improve it? I think there's a couple of pieces. For some patients, they're going to need really regular follow-ups where we're checking things like lab work for folks that might be at risk for secondary malignancies, echocardiograms for folks that might be at risk for late development of heart disease, for example, folks who've gotten anthracyclines. We know that there are higher rates of things like thyroid disease, heart disease, especially depending on where somebody might have received radiation. So I think one piece is this sort of medical and late effect surveillance, and that's really critical. And I think we don't do that good of a job of it. The second is, and I think something we really struggle to do in the medical field, is the social reintegration, if you will, vocational training. They may be left with disabilities, right? Again, the patients I treat with bone sarcomas, maybe they've had an amputation or some significant surgery that's left them with functional impairment. How do we help them reintegrate to the workforce? If they don't have a partner, how do they reintegrate into the dating scene and find a partner for the long term? How do we help them navigate the fertility challenges that folks are often left with? So those are some of the elements of survivorship care. I think the way to do it, what we do at UNC is we try to house a lot of those services in the same place. And so we have folks come back after they're done with treatment and see one of our pediatric oncologists, one of our nurse practitioners, and they really hold the keys to all these places that we can refer folks to help get those needs met. They go through and systematically screen for these kinds of issues and then get them connected with the services that they need.
What would you say to a colleague who's interested in starting an AYA cancer program at their own center?
So this is really a big part of the mission behind this piece that we were fortunate enough to put out in the ACCC, is trying to communicate with our colleagues who are taking care of AYAs outside of academic centers, but are taking excellent cancer care of these patients. The first thing I want to acknowledge is that AYAs may only be one or two or, certainly less than 10 patients that you might see in a month. And yet sometimes this is a patient population that may feel like the most challenging. And that's both because the emotional thing of seeing a 25-year-old go through cancer treatment is hard on all of us, but also because of all these needs, right? You're pulled into how do they manage their childcare? How do they manage their job? It's a lot more than if you're managing somebody in their 80s with prostate cancer. And so it's certainly a population with a lot of need, but I think there's also a lot of resources to support folks that are interested in taking better care of this population and ways for that when you see an AYA walk in the door, rather than for that to feel like a negative emotion, but rather, oh, this is somebody who we can really help by getting them plugged in to what they need. So I think the first thing I would recommend is sort of look at your clinic, look at the resources that you have, and figure out what are the priorities that feel like you are either resourced for or that you're most excited about. Because there are so many needs and ways that we can support young adults that you should pick the things that are going to fit into your own strengths and your own interests. If fertility preservation feels like something that you're really excited about talking with patients about, then there are tons of national resources about educational stuff, about how to have the conversation with patients, sexual health materials. There's lots that can be provided to support that. Whereas if that's not something that you feel that you have the bandwidth or interest in engaging in, then what I would recommend is be aware of the referrals that you can make. Just know who to call so that you can send a patient so that the patient can get what they need. We've tried to include a lot of resources in this publication of things like psychosocial support, again, sexual health, palliative care, long-term surveillance. So all of these different elements of care, I think choose something that feels worthwhile and then engage with the resources that are in that space. And the last comment I would make is that nobody should be trying to do all of these things. It's just too much. Even at a well-resourced cancer center like ours, with a really big and robust program like ours, we choose not to do certain things, like patient support groups. There are national organizations that have patient support groups through websites. It just doesn't make sense for us to try to reinvent that wheel and do it here at UNC. And so similarly, I would encourage clinics to be aware of the resources so that they can refer folks. And then if interested, pick one or two things that you feel like you can do well and can be passionate about so that you can advance care for this population.
Dr. Allison Manikowski is the program pediatric psychologist on the UNC team. She's here to tell us about the psychosocial factors AYAs with cancer face.
Our AYAs have kind of unique outcomes in things like quality of life post-treatment and even during treatment compared to like other cancer patients who are not AYAs. So for me, I often see our patients who are younger. So I'm seeing our peds patients that might fall in that sort of birth to 13 or 15 age range who we don't define in that AYA population. And so when I think of things, psychosocial needs, I'm thinking of things like treatment-related quality of life. And we know that that actually looks really different for our AYAs, which is why we're focusing specifically on some of those psychosocial needs. There's also things like some of the kind of more common psychosocial needs that are very different for our AYAs are things that they're focusing on, like completing education, establishing their careers, building families, having some form of independence. And I think those are very unique psychosocial needs that we know are different for our AYAs.
Talk to us more about the importance of discussing fertility options with AYA patients.
It's really important. It's a great question. I'm glad you're asking about it. So we as a team find it so important that we actually have somebody dedicated on our team to help with fertility preservation questions, support, and guidance. And so we're really lucky to have kind of that dedicated support where our patients can access really unique, tailored recommendations from somebody who is able to look at their treatment plan, coordinate with their medical team, and help them identify what, if any, options exist for them. We know, like the research has shown that while not all options may be feasible for many reasons for people, it may be the timing of their treatment, it may be financial circumstances. There's many reasons why fertility preservation may or may not be available. But what we know is that patients have kind of shown across the board that they prefer to at least have been approached and educated about what does or does not exist. And that could be before treatment starts or after treatment, like what continued fertility monitoring might look like and what treatments may exist afterward. And patients like having access to that information to, again, make an informed decision and feel good about sort of their next steps forward. We have heard from families that when they are not presented with that information, whether that is the family or that is the young person, afterward, they may have some frustration, regret, confusion about why they weren't just offered the opportunity to know that those things may or may not exist for them. And so we find that really important because, again, if you think developmentally about this period, anywhere from 15 to 39, this is a time when our patients may be starting to think about what that looks like for them. They may be considering that they want a future that involves children or building a family. They may not be sure of that, but maybe they want to have that option or know what may exist to help them monitor that in the future. And so we know that's just a really unique developmental period where that is often on the minds of many of our patients, or maybe they have started a family, but they want to know, how could they potentially expand upon that in the future should they want to be able to do that. So we find this to be a really important part of AYA cancer care.
What's the best way to talk about long-term effects with these patients?
My approach, and I think that as a team, we try to take this approach, especially thinking of our AYA lens, is that patients want to be able to have the opportunity to receive information. They may not at all times during their treatment feel open or ready to receive information, but I have found pretty unanimously that our AYA patients want to know that they can receive any and all information. And so I think sometimes what happens in cancer care and maybe in any sort of medically directed care is that we're targeting treating the cancer and we're trying to kind of optimize getting that treatment started from a medical lens. But that may mean that we're sort of overlooking or just not spending enough time sharing about those potential late effects and long-term impacts. And so when I think of meeting a patient for the first time, anytime that I'm doing a new consult with an AYA patient, I often outline from the very beginning some things that we know other AYAs often seek support from. That could be at the beginning, during, or after treatment. And so I try to lay that out for patients so that it just normalizes the fact that some of these late effects may exist, and those might be psychosocial late effects, and that we are available should they want that support. So I try to really be upfront about some of those things. For example, when I meet a patient for the first time, I kind of go through, we have a little brochure that we give to all of our newly diagnosed AYAs, and I'll go through and point out on the brochure some of the very specific things that we know AYAs deal with, again, at the outset of treatment, in the middle of treatment, and after treatment. So that might be things like, social connections, impact on relationships and education, impact on mood, impact on things like body image, physical functioning, changes in independence, interruptions in their life. And so I just really like to point those out from the outset, because I will have patients who may early on say, wait a second, I didn't know that was something I needed to be aware of. And I would say more often than not, it comes up a little bit later when people have had time to process, and then they're starting to really think about they're experiencing and starting to think about the impact of their treatment. And so we've already sort of normalized from the outset, these things may come up for you. We hear that many other AYAs experience these things, and that's why we're here to be a support and to try and help you through your whole care. So that is including survivorship, treating you as a whole.
What would you like to leave us with about treating this patient population?
I think that something that is really unique about our team is that we have multidisciplinary providers who talk about both the benefits and challenges of that person being treated on the adult or pediatric side based on their medical diagnosis, because there may just be different access or education opportunities, things like trial enrollment, if they are enrolled either on the pediatric or the adult side, but then also thinking about the psychosocial aspects of that person's care. So, on our pediatric side, oftentimes we're thinking that, we are often more prescriptive. We're kind of telling patients and families what the treatment plan will look like, or really guiding them with a roadmap. And the family is often guiding the medical decision making. Whereas if you think of someone served on the adult side, we may be thinking of more of a collaborative approach to the treatment plan, kind of empowering people to make their own decisions, and the individual empowering them to be their own medical decision maker aside from their family. And so I think that that's a really cool and unique thing we do a lot. And we also try to focus on preparing our older adolescents who will soon become emerging adults to kind of move from that pediatric lens of care to the adult care lens. And that is somewhere we continue to want to improve what we're doing and make that more streamlined so that our patients feel empowered to be their own medical decision makers when they become 22 or 18 and they're served in our adult care.
Thank you to our guests today. You can click on the show notes for resources on working with AYAs. You'll find a link to the full Oncology Issues article. Until next time, for the Cancer Buzz team, this is Summer Johnson.
This show is a resource of the Association of Cancer Care Centers.